Thank you very much for that welcome. It's a pleasure to be a part of the community. It's a pleasure to be here today at this event. Also, importantly, it's a pleasure to see faces that have also impacted me in many ways that you can imagine. So talking about the personalization of myeloma care. So these are my brief disclosures. So I mean, and the growing and expanding armamentarium of treatments for myeloma is very, very remarkable and interesting. Initially, the goal of treatment of myeloma which was thought to be incurable, has now moved to being treatable, and now we're looking at best outcomes in terms of the depth of response, deep and durable remissions. In the same vein, we're also beginning to identify better ways to be able to track the disease in terms of how much disease is left. If you could just conceptualize or imagine what an iceberg would look like, understanding that much of the disease above sea level is where we can actually identify symptoms and imaging, essentially, as well as some of our regular conventional testing. But the disease burden does extend way deeper beyond sea level. And therefore, when we've been able to treat the disease, the amount of disease that is left over, all right, especially when we've gotten a very, very good and deep response, is what we consider to be the minimal residual disease. And the minimal residual disease burden here, or measurable depending on who you're talking to, it's either if it's detectable or it's undetectable. And when it's undetectable, it's referred to as a negative, a minimal residual disease negativity, where we're unable to identify one or less than one clonal cancer or myeloma cell per 100,000 bone marrow cells. And I'm going to dig deeper, but more importantly, what we need to know is that this has turned out to be one of the strongest factors in trying to identify how well patients do. And it does help us in terms of trying to evaluate the effectiveness of our treatments. All right, it asks certain crucial questions. One, is the treatment working? And the treatment, one of the ways we can assess that is our conventional serologic test, like the SPEP, UPEP, the serum fluid light chains, etc. All right, and then that, you can get some information that kind of directs what the care should look like. Moving forward, how deep is the response when we're able to get a response? All right, and that helps to kind of refine what kind of characteristics, and once again determine there's certain consequences of that information we'll talk about much later. And can it also help us identify new drugs using this particular piece of information, this minimal residual disease, as a surrogate? Now, just to give a better sense of what we're talking about here, usually the deeper the response, the less likelihood that the disease is going to come pretty soon. And the graph here essentially just shows how much tumor cells are evident when you have just a partial response, as opposed to when you have a really, 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 really deep response. And the last graph that's in green basically is one that kind of tells us what a minimal residual disease response looks like, because as you can tell, the disease is less likely to come back much sooner. We know there's been a growing body of evidence that has told us that when we are able to get a very, very deep response, we improve outcomes of patients who are treated with multiple myeloma. Prior to this, the outcome measures that we used to use, the survival measures we used, were progression-free survival as well as the overall survival, because some of the metrics that are important in terms of caring for myeloma is how well are we able to keep patients out of the hospital from symptoms of the disease? Can we prolong life? And, more importantly, what is the quality of life as a consequence of the treatment that we've administered. And therefore, these are all studies basically that tell us that, when we're able to get a very, very deep response and durable response, that ultimately translates into improved survival outcomes, like the progression-free survival as well as the overall survival. And this graph here basically just tells us that until recently, when the gold standard was a complete response, we know that with patients who had complete responses essentially lived much longer. But with the addition of the ability to identify what the minimal residual disease is, as you can tell here, basically, when we're able to parse out how much minimal residual disease there is in patients who have a complete response, if it's negative, we understand here that this graph, as flat as it looks, pretty much translates to how well or how long patients are living, in spite of the fact that, with the well-known scenario here that they are MRD negative, or there's much of a lower burden of disease remaining, as opposed to a scenario where there's still some evidence or detectable disease left after therapy. Survival here diminishes significantly. Now, what are some of the approaches that we have? It can be bone marrow based or it can be peripheral blood based. The bone marrow based ones are what we refer to as the next generation flow cytometry, which is actually what pretty much looks for. The easier way to describe it is being able to count the cancer cells, the myeloma cells, right? And while the next generation sequencing is when we're able to identify or count the clones, some clonal immunoglobulin sequences of the myeloma cells. And both of these testing modalities are able to identify or have a sensitivity of being able to identify one myeloma cell in about 1 million cells in general. And just because of how successful this ability was, it was incorporated as part of the response criteria in 2016 by the overall body that is responsible for the treatment of myeloma. And you could ask the question, is there any concordance between both of these testing modalities? Yes, indeed, because there was a study that was done at Memorial Sloan Kettering on about 251 patients that demonstrated about 93% concordance rate between both the NGS and the flow cytometry. Now, there are other newer blood-based techniques, albeit still in clinical trial phases. These ones essentially, like has been mentioned before, mass spectrometry, and sometimes we can actually identify plasma cells when they circulate in the peripheral blood. And the last one that's called a liquid biopsy, where we're essentially just looking to identify DNA circulating, the DNA of the myeloma cells that are circulating within the peripheral blood. And with ongoing studies, the depth of response here, the sensitivity of this testing can actually go into identify myeloma cells within 10 million cells. Now, it's certainly incorporated as a clinical trial endpoint, and just like I mentioned, it helps to identify the depth of response that's achieved with either new treatment or combination treatment. It can help in identifying the efficacy of different strategies, as well as, like I mentioned earlier, being used as a surrogate for survival outcomes, which we knew, which we were using before. Just like I said, just because of how long the survival outcomes are stretching with the new therapies that we have. The minimal residual disease is an option right now that can tell without having to wait for so long. And the proof of this basically is in some of the studies here that I highlighted. The determinations trial, which pretty much just try to test the role of transplant in patients who were treated with the triplet combination and ultimately went on to receive consolidation with Revlimid, Velcade, and the steroid, and subsequently maintained on Revlimid. Now, what's more important here in all of these different trials, which I've separated into those that are eligible, those are for patients who are going to be going into transplant and those that are not going to be going into transplant, is to identify that this is increasingly becoming a surrogate, is increasingly becoming an ideal data point that we obtain in patients being treated for myeloma. And the depth of responses here are generally in the order of 1 in 100,000 cells to a million cells. And of course, on the right-hand side of the slide here, you find out that the MRD negativity rates here are quite impressive, especially when you see the addition of one of the newer or novel treatments for myeloma, which is the monoclonal antibody daratumumab in this case. These are other trials that have potentially resulted right now that pretty much use the minimal residual disease to test or to direct treatment strategies, right? Some of the more important ones here are the master trial, basically, that essentially just was a very, very intense treatment regimen where patients received a combination of the monoclonal antibody and a triplet, and then they went on to transplant, and then they received 4 more cycles, and subsequently another 4 cycles. And what was also crucial to understand here was that the MRD was tested at these stages, and if patients were able to get MRD negative in 2 consecutive times, they essentially were monitored without additional treatment. There are other more important trials here that essentially are driven or utilize MRD here as one of the data points that we require that may ultimately drive what treatment monitoring would look like. Now, is MRD also utilized in other immunotherapeutic approaches? Absolutely. These are some of the trials essentially that have utilized MRD testing in CAR-T and bispecific antibodies. And you can see here, once again, using this as a surrogate, it can actually tell you just how effective these medications are, these treatment strategies are, and it gives an idea of what survival outcomes would look like from progression-free survival as well as overall survival. What are the optimal timelines for measurable or minimal residual disease assessment? We don't know what the ideal is for now. There are a lot of clinical trials ongoing to identify that. What a lot of these trials have done essentially has to do this testing post-induction after the initial treatment to bring down the disease burden, after transplant, and sometime during the course of the maintenance therapy. But what we know is that using a single time point is probably not the most informative. Several evaluations tend to give us more information just because of how dynamic the MRD nature is. And it's referred to as a sustained MRD negativity when we can get 2 time points that are negative. And currently, trials ongoing with 6 months, 1 year, and even 2 years are being evaluated. In the real world, right, this was a study basically that was done that actually showed that once you're able to get a 3-year duration of MRD negativity, the likelihood of staying free from the symptoms of multiple myeloma was in the order of 64.4%. And if it was much more prolonged, adding 1 or 2 more years, the likelihood of an increased 5-year PFS rate here, which is the disease not causing much in the way of symptoms, were as high as 97.9 and 100% respectively. This kind of essentially demonstrated that it did have incremental benefit. The longer you were away from, the longer you were with a negative MRD status, the better it was from a survival outcome. This was another study basically that, we're in the era of artificial intelligence, still in the beginning stages. This basically just showed here that MRD negativity, which is what we're beginning to understand, the ability to be able to identify or not identify any myeloma cells in about 1 million cells, essentially was associated with very great outcomes, right? And more importantly, when we followed it on a longitudinal basis, it predicted very, very favorable outcomes. But what was more important was when using AI capability, we're able to identify certain, this is more of a deep dive testing, certain clonal sequences, like when you had what we refer to as polyclonal sequences, many different types of immunoglobulins, essentially, that correlated with more of a prolonged progression-free survival from myeloma in patients who had multiple myeloma. So what are some of the limitations of minimal residual disease testing? Right now, we don't have any consistent guidelines to direct standardization. And sometimes some of the different methods of testing can lead to varying results. Some of them may be quite invasive, like I mentioned earlier, especially the two that are much more commonly adopted right now, the next generation flow cytometry as well as the next generation sequencing. And the fact that we need to do these bone marrow evaluations quite frequently may limit the frequency. And of course, more importantly, limited access, right? And this may also be one of the limitations to the assessment. But, work continues to go within the clinical trial sphere to ensure how we can overcome some of these limitations. More importantly, the combination of imaging, because like I mentioned, multiple myeloma can be quite patchy, all right? So you may do a bone marrow evaluation and may really get a very good depth of response and not see a lot of myeloma cells. But when you combine that with very high resolution imaging like a PET CT or even a MRI, to exclude the possibility of a collection of myeloma cells elsewhere, that ultimately improves the sensitivity of this data, and we can predict to a reasonable extent, just how well or how much benefit you've gotten from the treatment so far. What is indeed the path to MRD negativity? Having access to some of the novel treatments that are available on ground today. The quadruplet therapy, which is just the combination of most of the targeted therapies that we use to decrease the symptoms and the burden of the disease, and subsequently to ensure that we can keep a foothold on the disease beyond transplant if the patient is eligible for transplant or not, right? And once again, transplant, if the autologous stem cell transplant, if the individual is a candidate for transplant. The new kids on the block, the T-cell engagers, basically the immunotherapeutic approaches, wherein we leverage our immune systems, principally the T-cells, to be able to direct them to identify myeloma cells and kill them effectively. And of course, it comes with the added benefit of being way more tolerable, albeit with a different side effect profile. And last but not the least, clinical trials. Clinical trials essentially continue to be a resounding option that we can add to the journey of MRD negativity. From a precision approach standpoint, it helps to inform prognosis from a summary standpoint, idea. It gives us an idea of what the long-term outcomes of the treatments that we're receiving. It helps us, has a better understanding. It helps us to guide decisions in terms of if we see a patient who has persistently remained MRD positive, that doesn't mean we may necessarily have to change what we're doing, but it gives us an idea in terms of what to expect. All right, and depending on the paradigm, depending on the phase of the treatment, if we have to intensify treatment or if we have to decrease the amount of treatment. For instance, for low-risk patients, do we necessarily have to give a lot of aggressive treatment? Or for high-risk patients, do we have to make sure we're optimizing the treatments that we have available to be able to get to this endpoint? And segueing into the third, it does help in modification of therapy, like I mentioned, and it's been very helpful from a regulatory standpoint, since the FDA recognized MRD as a disease, a surrogate. It's pretty much as it's a measure of success in myeloma trials that helps us to identify how well the treatments are working. And with the FDA's acceptance, we can actually use it as a marker. Up until recently, like I said, with the great treatments that we're having right now, you're having survival outcomes that are stretching into 5 years and 8 years. That's a little too long to be able to approve medications based on these markers. But when you have a data point like an MRD that you can obtain within 6 months or 1 year, it actually helps with bringing newer drugs approved into the landscape of things. Just, for future directions, there are a lot of MRD-driven trials that are ongoing that would help test MRD-adapted strategies, whether we need to intensify treatment or de-escalate treatments. There are studies essentially that would integrate other biomarkers, like combining it with other information that we can get, like the cytogenetics, genomics, essentially, to give us a better risk assessment of what the disease is looking like. And like I mentioned earlier, some of the peripheral blood-based MRD testing techniques are an opportunity to research into less invasive, because you can it's just a blood draw as opposed to being subjected to a bone marrow biopsy frequently. And we'll continue to work essentially to standardize the assessment of minimal residual disease as well as its reporting. And clearly, from not every patient may have an opportunity to be involved in clinical trials. Sometimes, if patients have done very well, especially in the maintenance setting after induction transplant, and we've been on Revlimid for a good amount of time, there may be toxicities, there may be side effects, or sometimes there may be side effects that prove to be prohibitive, and we can use this as a guide to decide if we go off of these maintenance therapies while we continue to monitor closely. All right, moving on into some of the disparities that may occur in the treatment of multiple myeloma. Now, we're very well aware that from an incidence perspective, Black patients tend to have the highest rate of multiple myeloma of any ethnic group all around the world. And more importantly, it's highlighted here. It's almost twice. Black patients tend to have twice as much myeloma incidence when compared to our Caucasian counterparts. And with Black patients having the disease almost twice as much, that means that, there's also an increased mortality or death from the disease when compared to other ethnic groups. It tends to be there are subtle differences that may occur in Black patients that unfortunately have multiple myeloma. It does present at 4 years earlier than white counterparts, and there may be more of an increased end organ damage. By end organ damage, I mean that it may present with more anemia, higher calcium levels, and impact the kidneys a little bit more frequently. We also know from studies that Black patients tend to have more translocations on the 14th chromosome, which is one of the chromosomes that actually directs myeloma, the development of multiple myeloma. Also, we know that Black patients are less likely to have higher risk diseases like 17p deletions and amplification of the 1q chromosome, which which also ultimately kind of expands the care gap here, because you think that with a standard risk disease, which is how we define how aggressive the disease may be, you expect the outcomes to be better, but that is not the case, which actually informs us that there may be other factors that may contribute to the less than optimal care in this case. When it comes to utilization of certain treatment modalities, it's from a study looking at the database of folks who have had multiple myeloma dating back to 2007. It was clear here that Black patients tended to use the triplet therapies. The triplet therapies are a combination of drugs before the advent of the monoclonal antibodies. Black patients tended to use triplet therapies a little bit less, and also tended to have less of an access to stem cell transplant. Hispanic patients, of course, also were less likely to start Velcade earlier, and there was also low utilization of stem cell transplant. A different study essentially found out that compared to white patients, Black patients did not really receive cytogenetic testing as well. Regarding utilizing the same database from as far back as 2007 to 2013, it was identified that Black and Hispanic patients had a longer time from their diagnosis of multiple myeloma to start this novel treatment. But over the years, there has been an increase in the start of novel treatments, especially within the first 6 months of therapy, as highlighted from the graph here to the right. Some of the gaps that have also been identified, like I mentioned earlier, were the utilization of transplant. And from this study here that was done in over 22,000 patients from the database of patients that undergo myeloma in the country, between 2005 to 2009, it was identified that persons of color generally have lower utilization rates. And these disparities essentially prevent approximately 1 in 7 potential transplant procedures for multiple myeloma patients. In general, when we looked at taking into consideration over 12,000 patients who had the disease, some of the factors that were associated with a lower likelihood of utilizing transplant were Black, Asians, and Hispanic ethnicity, an older age, or low income or lower level of education, when you resided in a metro area, and a lack of medical insurance. All right, and even when you adjusted for income and education level, some of these gaps still persisted, pretty prevalent, especially with persons of color, when there were issues with insurance and or Medicaid coverage. Of course, there's also been the possibility that there's a role played between patient and physician bias in terms of having to identify appropriate patients for transplant, which is why it's always crucial to have patients evaluated, more importantly, by a transplant physician. One of the methods to ensure control of bony disease in patients who have multiple myeloma is the use of certain bone modifying agents. And this study also, once again, though a retrospective study, was important in highlighting that there was an underuse of this treatment amongst persons of color, especially blacks and Hispanics, when compared to their Asian and white counterparts. And when you looked at it, when you did a deeper dive into some of the statistical reasons, right? The black patients and having Medicaid as an insurance were some of the major predictors of underuse of this therapy. A different kind of study kind of corroborated that there were higher use amongst Asian, white, and Latino patients when compared with black patients. But in another study with about over 14,000 patients who were aged 65 and above, right? This was it did note that more white patients tended to initiate this bisphosphonate therapy, which is a bone targeting agent, when compared to the black patients. Now, when we look at these, some of these disparities that we've been able to identify, much of which hinging on access, is there any difference when we're able to overcome issues of access, like in the VA health system, where most patients essentially have access to triplet therapies as well as transplant? You find out that in the outcomes that was studied in patients between over a 17-year period from 2000 to 2017, black patients, when those access issues were corrected for, especially those who were younger, less than 65 years old, actually had a longer survival. They lived much longer when compared to our white counterparts. But that difference was not so significant in patients who were much older, maybe because they were considered to be poor candidates for transplant. And once again, it was very evident here that there were no racial disparities at the VA in terms of the overall use of novel agents and or transplant. When we consider the treatment of multiple myeloma, multiple myeloma is a heterogeneous disease, and we do have a very heterogeneous population here, and therefore it's crucial to be able to, in our goal of trying to control the disease better and even maybe imagine the lofty ideal of cure, we have to look for ways to be able to deconstruct the disease. One of the easier ways here would be looking at different ethnic groups that have the disease, and sometimes, right, our medications, our therapies essentially may work differently in different populations, right? And therefore, a lot of studies encourage to identify some of these differences that may occur, right? Because there may be certain genomic differences that occur in terms of how we individually respond or deal with medications when they are absorbed, when they're kind of distributed or peripherally transported to different organs, how the body breaks them down, and how the body essentially excretes them. So in one of the earlier trials that led to the approval of the class of Revlimid called immunomodulators, less than 2% of that population was black. However, in a real-world situation at the Boston Medical Center, when it was studied over a 7-year period through 2020, 106 patients, out of 106 patients, 20 of such patients who were black and 2 who were non-black were reported to have hyperpigmentation or skin darkening. This is vital information, of course, that essentially was made known to us just by the fact that there was more of this population or this ethnic group that was studied in this clinical trial. Are there also racial differences that may occur with the the newer immunotherapeutic approaches? Absolutely, we're beginning to find that out. And this is a study essentially that was done on 207 patients who were treated with CAR T. 11% were Hispanic, 17 were Black, and 72% were white. It was identified that Black patients were more likely to develop cytokine release syndrome, which is one of the more dreaded side effects of CAR T in this case. However, the overall response was lower more in our Hispanic counterparts as opposed to the Black and white and Black and white patients. There were no differences that were identified in some of the survival outcomes. Taking a deeper dive into another landmark study that was done called the Determination Trial, which pretty much was a trial that studied the role of transplant, right, in patients who were induced with the triplet therapy of bortezomib, lenalidomide, and dexamethasone, and subsequently were randomized to either receiving transplant or not, but ultimately received additional cycles of the triplet and went on to continue with maintenance lenalidomide. Overall, right, in the population that had the induction and the transplant, there was no, it was associated with a longer progression-free survival, not an overall survival benefit. And in this cohort, about 18% of patients were Black. And for the Black patients, the progression-free survival here for the group that didn't have the transplant actually was not reached in comparison to about 61.4 months for the group that had the transplant. Now, that doesn't mean that transplant does not work for Black patients. It simply means that it's an opportunity to have a conversation with your physician in context with every other information to determine if transplant may be a deferred strategy, all right, at that point in time. But when you look at it in totality, the median progression survival was longer in patients who also, in Black patients who had transplant, especially those who had a BMI of over 30. Some of the conclusions, I know this was a pretty quick presentation. I was a little bit concerned about time, but some of the conclusions here are that patients of African descent, like I mentioned, have twice the incidence of multiple myeloma and the pre-malignant state of multiple myeloma, which is called the monoclonal gammopathy of undetermined significance, than other ethnicities. And the biology and presentation of multiple myeloma in patients of African descent does appear indeed to be different than those of European descent. And there are certainly disparities in the delivery of multiple myeloma treatment, especially with transplant. And like I said, the idea here is for those in which our therapies are working, we have to look for ways to make them work even better. And for those in which the therapies don't seem to be working, we need to identify why those therapies are not working so that we can begin to get as much survival outcomes like we're having in other ethnic groups. And the goal here is to be able to attain great myeloma care in terms of treatments for patients via optimal disease control, and once again, if we're lucky enough in our lifetime, cure. Some of the other contributions to improved survival for all of our patients who have multiple myeloma include access to novel therapies like these quadruplets that involve the use of monoclonal antibodies, access to stem cell transplants, access to the use of these T-cell engagers, these immunotherapeutic approaches that are the buzz of the moment right now, and clinical trials. All of this in combination certainly would improve the survival of our multiple myeloma patients. I want to thank you for the opportunity, and it's a pleasure to be here today.